Good morning. So, after this excellent introduction to vertigo, let us try to focus only on BPPV and what maneuver to do. So, you have a number of flavors. Like if you walk into an ice cream shop, sometimes you can get confused what to do. But studies have shown that the main three ones which people choose are vanilla, chocolate, and strawberry. So, I'm going to focus on three main maneuvers that you should look at. You can get confused trying to look at all the various maneuvers, including their names. More and more new maneuvers are constantly being discovered. So you should like vertigo. Somebody said, I mean, many people said that when a patient says he's dizzy, the doctor also feels equally dizzy or sometimes even more dizzy. But I think you should like the symptom. It's very common. In Mumbai, for example, there will be 200 patients of BPPV every day. In Pune, we have about 60 every day. I hardly get 2 or 3 out of them. The remaining either receive drugs or they get so-called repositioning. Okay, so it's very rewarding and very treatable. Remember, these patients are extremely scared. This was just to show how scared they are. Untreated BPPV has a high fall risk. It really affects their quality of life. This woman had been sleeping like this for the last many years. So there is reduced quality of life and it is really treatable. So I'm going to talk about what I don't do, what I usually do, and sometimes what I rarely do. So what do I not do? When a person comes with chakkar, you examine and say you have vertigo. All that you do is translate from Hindi into English. You have called it vertigo. You don't tell what. I have so many times patient who comes to me after seeing 3-4 doctors and I tell him, what were you told was the diagnosis? He says vertigo. So I said, what do you mean by vertigo? He looks at me as if I don't understand what is vertigo. So people or doctors don't understand that vertigo is not a diagnosis. It's just a symptom. So you have to find out what is the cause. Anyway, that is what is often done. Then an X-ray is done, and when he comes back with the report of spondylosis, you smile. See, I expected it. This is spondylosis. Or then, if X-ray is normal, you check the BP and either call it low BP, high BP, depending on whatever. Finally, if the patient is everything is normal, no BP, no spondylosis, then you look at his age. If he's old, diabetic hypertension, you say probably vertebrobasilar insufficiency. And if you're driven to the wall, kuch bhi nahi hai, then you just say some problem in your inner fluid. Then what is done? MRI, MR angio, MRI of the cervical spine, the whole battery is done. Vertigo battery it's called. And then after that, some people have now started doing these, getting unsigned VNG reports. It comes from the cloud. Nobody knows what is written. Nobody interprets it. Nobody signs it. Neither the person who sends the report nor the person who receives it. But finally what is done? They do something. They call it an EPLI because you have to do a repositioning maneuver now. If you have BPPV, everybody knows that you have to do. So they do something, kuch to bhi, finally give drug. So just remember, BPPV is otoconia gone into the wrong place, and all that you need to do is reposition it, get it back to where it was supposed to be. So repositioning should be the primary treatment of BPPV. There is no role for drugs. Various studies have shown that it is far superior. So remember, this is one chance we have to do magic. I have had patients who went back to their treating doctor and said, I'll never go back to that doctor. He said, why? He's not a doctor, he's a Baba man. He puts his hand on the head and just did like this, and my vertigo for so many months I was having, it's gone. They don't understand the particles are moving. They just feel the vertigo is gone somehow. So the history, as Dr. Jacob rightly pointed out, history can be unmistakable. When the patient says he gets dizzy on lying down, most likely it is BPP. Getting up could be anything, even postural hypotension, etc. But lying down, turning in bed is very typical. This study has been done and we have replicated this. There are 3 questions to diagnose BPPV. Do you get a spinning sensation or a whirling sensation? Actually, now in our study, we found that this is not so important. Patients with BPPV may not complain of spinning. They might just say, I feel pressure in the head, I feel uneasy, I feel heavy. But if they feel dizzy mostly when they move their head, if he says yes, And if he says the duration is less than 3 minutes of spinning or whatever sensation, 80% of these patients will have vertigo. If the patient does not have this dizziness on moving the head, it is unlikely to be BPPV. So, three questions are very easy to diagnose even on the phone, and the next three questions could tell you which side. What makes you feel? Is it lying down in bed, looking up, looking down? Probably posterior canal. Is it turning in bed? Probably lateral canal. In fact, if the patient says, I woke up in the morning, I tried to get up and I felt dizzy and had to lie back again. I tried to get up, I had to lie back. That is posterior canal. If the patient gets vertigo in the middle of the night when he rolls over in bed from right to left while sleeping and suddenly vertigo starts, that is most often lateral canal. Then what makes you more dizzy? Is it turning on the right, turning on the left? All these questions can tell you pretty well 70 to 80%. Is it right ear? Is it left ear? Is it lateral canal? Is it posterior? Of course, this is all history. History is not enough. You have to provoke the attack. You have to see the nystagmus like Dr. Jacob showed you. And the simplest way is request the patient to show. The patient is an expert in avoiding the vertigo. So you just tell him, show me what do you get? How do you get it? And here is this patient showing us. You can see the upbeating torsional nystagmus of right posterior canal BPPV. So this patient was pretty severe or prolonged. Sometimes it could be just 1 or 2 beats. Sometimes you need a VNG, otherwise you cannot appreciate it. If the patient cannot demonstrate it, then you do a Dix-Hallpike maneuver. And this is how you do it. Turn the head to the right and take the patient down. You get a nystagmus. I will talk about this nystagmus later. It is down beating, not up beating. Okay, and then of course the roll test. So you tell the patient to roll onto one side and they get the nystagmus, sometimes with a latent period, sometimes without latent period. And if it's beating towards the bed or the ground, that is geotropic. Video frenzel makes it easier to see all these. There are different types of video frenzels. So here you can see the nystagmus very well, upbeating torsional. Of course, don't be happy when you find it on one side. Always check the other side also. Many patients can have bilateral. So that lady had on both sides. You did the same thing, side lying maneuver on the left, and she gets it on the left also. So we won't spend much time on this. Keep your eyes pricked. This was a patient who had ears pricked, who had migraine for around once in a month or so. He had tinnitus, deafness, left ear for 8 months, and now 2 days started getting brief attacks. So he was diagnosed as many years, tinnitus, deafness, and vertigo. But like Dr. Jacob again pointed out, vertigo of Meniere's should be more than 20 minutes. You cannot get brief attacks of positional vertigo. Therefore, even if he has tinnitus, even if he has deafness, do the side lying test, and such patients may have BPPV or sometimes they may have migraine. So this patient did have posterior canal. Important thing is get the proper angle. The head has to be 45 degrees. It has to hang down. If you don't get a proper angle, you may not get the nystagmus. Sometimes you have to vary the angle. It doesn't come at the typical angle. If the patient's symptom is typical, change the angle and see. It's very important to not allow the patient to close their eyes. If they close the eyes, you will not see the nystagmus. So you must make sure that you see the eyes. Give it enough time. Sometimes people just do a Dix-Hallpike 10-15 seconds and they are in a hurry. No. It may take up to 45 seconds. So give it enough time. If the patient's symptom is there, look carefully. Many reasons why it is missed. Patient didn't call it vertigo. He called it heaviness in the head, or he called it vague dizziness or whatever. Or he didn't say it was positional. So in general, it's so treatable and so easy that anybody complaining, even if he says D, the beginning of dizziness, even if it's not positional, even if it is lasting 10 minutes, check it. There's no harm in doing a Dix-Hallpike maneuver. So once you suspect, like I said, do the Dix-Hallpike. You will see the typical nystagmus there. If sometimes you have to modify the head position, this patient, first time we did, there is nothing. Then you try it again. in a little change the position, angle. Everybody's canals are not exactly the same. The anatomy sometimes varies. See there, on lifting the head, the patient got the typical nystagmus. So you have to look for it. Sometimes you do it, it doesn't come. Sometimes you have to repeat the Dix Halpeck and then you may get it. So the first time this patient is not getting, then you just take him up. Sometimes we shake the head and then do it. Basically, you want the particles to move. Okay, so the third attempt he got it. So problems with the Dix Halpeck, it's not done because there's no proper bed from where the head can hang out. So use the side lying position. You are kind to a patient who's got such severe vertigo, you don't want to do that drastic test, or you worry about so-called spondylosis. So do side lying test. Side lying, there's no problem with the neck, etc. Or you don't do it properly, don't give enough time, etc. So brander of exercises is, now we come to treatment. Brander of exercises, when you do that repeatedly, look to the right, fall on the left, look to the left, fall on the right, like Simont maneuver. And you do that, so 95% will get relieved. But the problem is that somebody who has severe vertigo is not going to do this. Somebody who has the vertigo and you do brander off, the particles will get shifted into multiple canals. So best treatment is repositioning, but if you cannot, or if you don't see any nystagmus, or if there's just mild, you can do brander off exercises. What is canalith repositioning? Basically get the particles out back into the otolith area where they came out from. And you know, those of you all who used to play this game, it's no longer available. Now we have all these computer games. But you know, that was a game I used to enjoy. So this, luckily it has come back. You know, we do the same thing. With VNG, it becomes easier. You can see little bit nystagmus. You can see the way the eyes are moving throughout the maneuver, and you know how it is moving in the canal. So if the nystagmus direction changes while you are doing the repositioning, you know it is wrong. You have to do it again. You know when to turn. As the nystagmus starts slowing down, you have to turn into the next position. So VNG definitely helps. And this actually it's a 1 minute cure. This lady was having vertigo, BPPV. After treatment, she didn't believe it. She said, "No, when I am sleeping in the afternoon, and the milkman comes, and then I get up and open the door. That is when I get." Now we couldn't call the milkman in our lab, so what we did was we told her husband, "You go out, knock on the door," and you know. Then she believed it when it actually happened. You can see her expression. You know, it's worth seeing that expression on a patient's face when they see the vertigo which was there for so long has just gone. She's lying down. We check immediately. Many people say no, not to check immediately, but I like to check immediately. Now she went, the husband rang the door, and now she's convinced finally. Okay, so now variants of BPPV, they can have symptoms on both sides. There are different maneuvers to elicit different nystagmus patterns. So the particles can lie in various positions, and I don't want to confuse you and make it complicated. There are different types of BPPVs depending on where the particle is, and the most common one is what you should focus on. So, you know, instead of remembering a whole telephone diary, just remember the 4-5 numbers that you need to, and that will make life easier. So I'm going to do that. That two conditions account for over 90 to 95% of BPPV. Posterior canal, typical geotropic posterior canal BPPV, and geotropic lateral canal. So about 80 to 90% is posterior, about 10 to 5%, 15 is geotropic. So I see maybe one apogeotropic lateral canal in 2 months. I see maybe a few apogeotropic posterior canals, but majority that we see are posterior canal, typical, and geotropic. So focus on that. Once you get confident in handling these two groups of patients, then you can bother about all the variants, scupulolithiasis, short arm, canal, whatever. You don't need to bother. There are number of maneuvers, and you can look at it all, and it's available in the YouTube. You don't need to. What we shall focus on is Simont, Epley, and the Guffoni maneuver. These are there's level 1 evidence for all these. They are easy. You can just learn how to do this. This is the Simont maneuver on this side, and the Epley maneuver. Basically, you can see the particles are being guided throughout. So the important thing about Simont is you have to, suppose I am treating the right posterior canal, I take the patient with the head turned to the left on the right side, and then you literally throw the patient like you're as if you are taking a cricket ball and throwing it. So you have to just move them fast from one position into the other, so that the particles will move like that. So the canal is like this. So if I do this way, now the canal is aligned in this direction. So that is how you have to do the Guffoni. There are a number of other maneuvers. I won't go into the details. Gans maneuver, liberatory. Now lateral canal, 10 to 15% of this, 70% of them are, at least 70% of the lateral canal are geotropic. Important thing is symptoms are on both sides. So which ear is affected? There are certain rules. I won't bore you with the details, but basically focus on geotropic. So when the person lies down, if you see nystagmus beating to the left, probably the right ear is affected. And if the nystagmus is more on lying on the right side, that is probably the ear. So there are rules, and once you start seeing geotropic, you may find it difficult. In posterior canal, it is easy because you do which side, only one side will get symptoms. But in geotropic, whether he turns on the left, he'll get, on the right also he will get. So the Guffoni maneuver is the one for geotropic. Again, very simple. If the right ear is affected, just ask the patient to fall on the left ear. After the nystagmus stops, turn the nose towards the bed and wait till the nystagmus completely stops. Barbecue rolls was the earlier method, but it is difficult to move. Particularly nowadays, lots of Indians are obese and our beds are small. To do a full barbecue, it's difficult. So you have to turn, then he has to get onto his stomach and then come up. It's difficult. So we've given up barbecue rolls. Of course, at home, I use that. Tell the patient if it's not going, lie down on a bed or lie down on the floor. Start on one side, keep rolling, come get up, again do that. So that is one way you can tell them to treat at home. Apogeotropic, again, if you Google, you'll find lots of maneuvers. There's this Guffoni's new maneuver, modified Simont, Kim's maneuver, and now the more famous Zuma maneuver. These are rare. Don't bother too much about it. I'll just take 2 minutes more. So you can get downbeat nystagmus, and that is a variant sometimes we see when treating posterior canal. The nystagmus which was upbeating now becomes downbeating. This is because the particle has gone into that, it's gone almost till the end and has not yet fallen. So it causes an opposite type of nystagmus. So this is a partially treated sort of posterior canal BPPV, and sometimes patients come with this. So the treatment for this is very simple. Instead of starting Simont from there, and you start from the half position, you do like this and just fall on the opposite, that is the normal ear. Dr. Ajay, what's like to write, study and publish lots of articles he's published. He's been gracious enough to put my name also on them. But he has done a lot of work on different rare types of BPPV, and you can see his YouTube videos, etc. There are, depending on where the particle is, they are classified into long arm, short arm, etc. They're light and heavy cupular syndrome, so leave them. I wouldn't bother too much about. Similarly, anterior canal is very, very, very rare. Don't bother. Do I ever use drugs? Severe patients, before PRM, sometimes patient is out of town, you can't do anything, or it's got a recent fracture or something. What do I rarely do? Sometimes my brother called me up from China, he got BPPV. I diagnosed on the phone and did a phone Simont. Similarly, I did that once for a patient from Indonesia, and the guy, we did a Skype call. After that, 2 years later, he calls me and he says, there's one patient, he's got BPPV. I tried doing that maneuver, you told him it's not going. So now he sent it to me. So it's difficult. Don't teach your patients how to do it. They might start treating themselves. And sometimes I do it on myself. I get BPPV every 6 months, so I get to practice Guffoni maneuvers on myself. So this is how I do. Finally, last, sitting up vertigo. Patients who have no nystagmus, but they lie down, there's nothing. They get up, they feel dizzy. So this used to be thought psychogenic. It is a type of BPPV. It is very often short arm. And again, Ajay will tell you how to treat these. Uh, be careful. Not all patients are of BPPV or BPPV. This patient was treated as BPPV, but his nystagmus is gaze evoked, and he had tuberculomas in the posterior fossa. Sometimes subjective patients might have a tumor. So if you don't see nystagmus, patient has positional dizziness, be careful. It could be a tumor. This guy had started getting positional vertigo when his son fell on his head. His VNG showed this typical epigeotropic pattern of nystagmus. Two neurologists had tried repositioning, it didn't go. And what he had was this big tumor in the posterior fossa. So be careful when the nystagmus is atypical, there is no latency, it's prolonged, and you are unable to reposition, it could be central. So finally, very common and very disabling disorder, often missed, very easily treated by repositioning. Drugs are not needed, despite whatever certain experts might tell you, no role for drugs. Different canals need different maneuvers, and VNG makes life easier, of course. How do I treat? Reposition if possible, if not, or mild, Branderoff. Anxiolytics, SOS for 2 or 3 days after that. Very rarely antiemetics, sometimes before repositioning, and anti-vertigo drugs only if out of town. So, to end, keep your ears pricked for BPPV. Even if it doesn't sound like BPPV, still rule it out. Try to see which canal is affected and look for the red flags. Thank you.